All right, today we're going to talk a little bit of ultrasound or aorta ultrasound specifically, and we're going to do kind of a back to the basics type lecture. I know Catherine's going to do a little bit more next week with renal, but today we're going to talk a little about aortic ultrasound because we're kind of finishing up this whole module that we've been doing with vascular ultrasound. And so one huge aspect of vascular ultrasound, at least as it pertains to bedside medicine, is the aorta. And so with that being said, we're going to talk a little bit about the aorta today, dive into the aorta and kind of some interesting things or some kind of bread and butter things that we need to know about doing bedside ultrasound of the aorta. So with that being said, I like to always start things off with a case, just really to set the stage, kind of get our minds engaged, make it a little bit more fun, kind of really put a HIPAA-proof face on, or name and face on the whole topic that we want to discuss. But today's case is rather unique. We're actually going to jump to a different species. We're not going to talk about Homo sapiens or human beings or whatever label, Latin-based label you want to put on it. We are going to talk about my garden hose. Yes, we're talking about my garden hose. So years ago, when we were at our previous house, which has no bearing on the nature of the outcome of the case, I had a particular garden hose, right? I used it to water my lawn, tried desperately to get my lawn to grow, despite the fact that there was a high concentration of ammonia-based substances that were from my dog that were preventing growth. Apparently, when you put too much fertilizer on your lawn, or canine-based fertilizer, it doesn't like it, right? And so despite my best efforts to plant seeds, to water, to appropriately chemically treat the lawn, it just was this patchwork of bare spots, right? But it is what it is, right? And I had this garden hose that I utilized to water said lawn. And I noticed one day that it was starting to develop some little bit of a bulging aneurysm in somewhere in the middle of the hose, right? And lo and behold, one day I was sitting in my kitchen. I must have had the window open because I could hear some outdoor sounds, and something sounded kind of odd. It kind of sounded off. And I looked out the window and noticed I had this on my hands, right? I don't know how long it had been leaking. I don't know how long it had ruptured, but I definitely had a ruptured, can't really call it abdominal. You can't really call it aortic, but you could call it a outdoor garden hose aneurysm, right? The thing ruptured and I was spewing water all over my yard. And at the time, since I was on city water at the time, it was a precious commodity that was paying for. And since I didn't want to pay for something that I wasn't receiving direct benefit from, it was necessary to go in and do some form of a Roboa-like procedure to terminate the flow of this liquid, this water, from the aneurysm in this patient. So I promptly got up, walked outside, hit the spigot, turned the dial on my Roboa-like procedure and terminated the flow of water, right? And was able to do then a postmortem autopsy of the hose and discover that it not only had ruptured, well, as suspected, since it was spewing water, I had ruptured not only the outer layer, the adventitial layer, but also that thick, fibrous media layer, right? The middle layer that was providing the structural integrity of the garden hose. And I had a ruptured garden hose aneurysm on my hands, and was able to then take the hose to surgery and find a connector that was able to basically splice out the ruptured portion, reconnect it, and regain the function of the garden hose. And I'm proud to say that as of the last time I had awareness of where this hose was, it was performing quite nicely and doing quite well, but I've subsequently lost accountability of this particular patient, and I couldn't tell you the current status of the patient as of today. So that is the case that we're going to start things off of today. Unique, albeit, but it is what it is, right? And I thought it was really interesting, especially as an ultrasound guy, when you start thinking about the world in terms of ultrasound, you start seeing ultrasound everywhere, right? And so, if you look on the back of a car on a very salty day, you can see a nice curvilinear array as the windshield wipers just clean off the back of someone's car, right? And in the same vein, I saw a ruptured AAA that desperately needed some form of ultrasound to diagnose this particular case before it ruptured. So with that being said, let's dive on into the actual topic for today. And what we're going to talk about is discuss the indications for aortic ultrasound. It'll be the first thing we're going to do. And then we'll talk a little bit about the sonographic findings of the aorta, right? And then talk about pitfalls in the scanning of the aorta. And in there, we'll talk a little bit about AAAs and kind of how we diagnose those and what they look like. And hopefully we can come out of the end of this conversation with a little bit more of a robust understanding of how to do aortic ultrasound so that we can benefit the patients that we see in our various clinical service areas, and help them out in this capacity, right? So before we get too far, this is an amazing article. It was published in 2014 in the New England Journal of Medicine, but they have a really, really nice review series. I've really enjoyed over the years reading the clinical review or clinical practice reviews in the New England Journal because they take a topic, right? And oftentimes they're decently related to emergency medicine, right? And they take this topic and they break down, a lot of the literature. You have a really long reference sheet and talk a little bit about the background and the presentations that you may see, the indications for whatever, and the data surrounding whatever that topic is and how you best assess and manage those patients, right? And so this particular one was on abdominal aortic aneurysms and published in 2014, so almost 10 years ago now, and it's a really helpful and very robust discussion about the topic, right? And I think it will serve as the basis for a lot of what we talk about today. And I definitely commend this paper to your own reading, because it's really, really helpful, right? Summarized it nicely. But as we go into the ultrasound, let's talk first a little about the indications for why we would want to do an abdominal aortic ultrasound, right? Or the reasons why the patient might have a AAA. And that's really the big thing, right? We're going to identify this patient has an aneurysm. And there's some secondary questions that we may be able to answer with ultrasound, but ultrasound may not be the best test that's suited for that. And that is this thing ruptured, or is there any intimal problems like an aortic dissection going on in this patient? And so the answer to those second two, we're really not going to cover a ton today, mostly because ultrasound isn't really the optimal study for, hey, I got a balloon, is it burst? Or do I have a dissection, in this aorta? You can see it, but if you're really concerned, you're probably gonna get some other imaging, right? So for AAA specifically, what are your indications for performing an ultrasound, right? And those indications are a number of things, right? A number of different clinical scenarios that can be the presentations for a AAA. And those would be abdominal pain, big one, right? Back pain, flank pain, hypotension, dizziness, syncope, and cardiac arrest, right? All of these are ways that the patient might present to the emergency department or to your clinical environment with a AAA. And it's actually kind of disconcerting to look at the list because you're like, man, this covers a large swath of the patients that I see in my department, right? In my main emergency department, and even in my fast track, right? A lot of people can fall into this bucket, and it'd be, definitely inappropriate to say that all patients with these conditions will have a AAA, but it's definitely not inappropriate to say that patients with these conditions might have a AAA, or AAAs present with symptoms such as these. And so when you see these things, particularly when you see belly pain and when you see back pain, right, you really have to think through, could the aorta be involved? And then, as we're doing our resuscitations, I know it doesn't really cross our minds frequently, but is this unstable patient unstable because of their aorta? And so one of my favorite questions for, young trainees, right, young residents or medical students, as they're presenting patients to me, and they're presenting patients, complaints that are something like this, right? If they have one of these complaints, I'll oftentimes ask them, hey, look, what's the top 5 things that you can think of right now that can cause this patient's, let's say, belly pain, right? And they'll give me 5 reasons. Okay, give me 5 more. And they give me 5 more, and they say, okay, give me 5 more. And they start scratching their heads and like, oh boy, I'm starting to plumb the depths of my knowledge, right? And I'll oftentimes really push for 5 more and 5 more until they hit the aorta, right? Because I think it's really, really important to think about the aorta when it comes to abdominal pain, back pain, flank pain. Doesn't mean you do something about it if you have good reasons to not do it, but you have to at least think about it, because you won't hit the diagnosis if you don't, right? So with that being said, abdominal pain, back pain, flank pain, hypotension, things that would be associated with either the swelling of this aorta or the loss of blood from the aorta, right? Now, for the aorta, the abdominal aortic aneurysm specifically, if you read through the textbooks, they're going to say, hey, look, if you're over 50, right? See the risk factors for a AAA to begin with, right? If you're over 50, right? If you have long-standing high blood pressure, if you're a smoker, or if you have a family history of a AAA, all of these things put you at risk for developing a AAA, right? And so if you have that person who is 65 with belly pain, who's been smoking like a chimney for their whole life, plus or minus that history of AAA, your family history of AAA, you have to think about it, right? Whereas if you have someone who's 20, who's not a smoker, who's fit and active, who's not hypertensive, who doesn't have a family history, maybe it's a little lower down or a lot lower down in your differential, and that may or may not cross the threshold of doing diagnostics, right? But if you think about it, when you hit these patients who are older, higher risk, have risk factors, right, you have to start considering, could AAA be part of this patient's presentation, and what do I need to do to work it up, right? Now, some interesting epidemiological statistical factors surrounding AAA. Only about 18% of the patients with a AAA will have a palpable mass, right? And I think this is remarkable to think about. And if you sit and think about your own clinical practice, like, this kind of makes sense. We're practicing here in the United States, right? We are all subjected to a very Western, style diet, right? Which tends to lead to excessive reserves of nutrients, right? That may obscure certain pathological, palpable findings in the abdomen, right? And so, there may be various reasons why it may be difficult to find a AAA in someone, on exam, right? You may have, it's just not big enough for you to feel, right? It may be that there's too much intra-abdominal fat, or, extra abdominal fat that kind of obscures the thing. So only about 18% of patients, have that palpable mass, who have a AAA, right? And what's scarier is when the thing goes, right? When that hose finally ruptures and it starts spewing water all over the grass, except it's not water, right? It's inside the patient now. 85 to 95% of people who have a ruptured AAA will pass away, right? It's got a mortality of 85 to 90%, which is actually quite frightening, and really makes it important for us to say, it's really, if I don't have a great track record of bringing them back after the thing blows, maybe I should probably start trying to find it before it goes and intervening before it goes to prevent mortality for that reason, right? And so that's going to drive a little bit of the screening that, that can be done at the bedside, on these patients, right? Now, what's also interesting is that 80% of people who have ruptured AAAs present with belly pain, and 60% of people with ruptured AAAs present with back pain. So if you're thinking in the context of what are my top 2 symptoms that I need to be most worried about, it's probably fair to say belly pain and back pain, right? You can't ignore the other ones, but if I at least think about that on all my patients with belly pain and back pain, you're off to a great start, right? Since a lot of those patients will present with those particular symptoms, right? And so interesting things to help us kind of as we go on our diagnostic quest for this thing. Now, the question is, okay, fine. Medicine is not a binary, or not typically a binary. It's often, found on a gradient. And so at what point along that gradient of size do I need to start becoming concerned, right? In this paper that we quoted from the New England Journal had a really, really nice chart. And here it is. And it basically says, hey, look, if you have an aneurysm, and the typical findings are 3 centimeters or less is normal, right, of your aorta. So if it's greater than 3 centimeters, but less than 5.5 centimeters, your 1-year risk of rupture is actually pretty decently low, right? 1%, is the risk of rupture every single year. If you're less than 5.5 centimeters. And, if you think about a lot of different things in medicine, we kind of use that 1% threshold a lot, right? And so you think about, acute coronary syndrome, like, can I get that risk of acute coronary syndrome down below 1%? And if I can get it down there somehow clinically, maybe I don't have to do some testing if their pretest probability is less than 1%, right? Or if I can get all my testing to get the post-test probability down less than 1%, I've done an adequate amount of testing, right? And further testing is really not going to provide much marginal benefit beyond all the expenses that we've had, right? And I mean, think about it for PE with the PERC score, right? Your post-test probability for PE, status post negative PERC score, is about 2%, right? And so, we're getting things down to a pretty manageable, pretty understandable risk, that we're comfortable with in a lot of other spheres in medicine once we're kind of under that 1% threshold. So less than 5.5 centimeters, your risk of rupture is decently low, right? But look what happens after you hit that 5.5 centimeter mark, right? Your 1% risk of rupture at 5.5 to 6 centimeters is 9%. risk per year, right? 9% incidence of rupture per year. Now, again, I said not everything's binary, and we have to categorize it in terms of these classes. So my suspicion is a lot of the data for less than 5.5% weren't clustering around the 5 or 5.5, centimeters. They're probably clustering around the, 3.5, 4 centimeters. However, the data is what it is. And so there's going to be a smoother gradient between 5.5 and 5.6. But just know, once you've hit that 5.5 to 6 centimeter mark, your risk starts going up substantially, right? And then you look at 6 centimeters, 6 to 7 centimeters, and you add another point of incidence of this thing. And then once you go beyond 7 centimeters, your incidence of rupture goes way up to the point where, like, just count on it, right? If you don't do anything. So the number that you should have in your head as you're scanning these patients of what's definitively pathologic is somewhere between 5 and 5.5 centimeters, right? To say, hey, I've hit this mark. I now need to be super duper concerned about the risk of rupture annually, right? And the reality is we're going to be consulting vascular surgery long before the patient hits 5 centimeters. But that is the definitive mark. But, past which you should say, you know what, this is going to be happening here. We're not going to send you home and work this up, 2, 3, 4 weeks later, right? So let's talk about normal findings of the aorta, right? And we'll talk about gross anatomy, and then we'll apply the ultrasound to that and see what that looks like sonographically. So from an anatomical standpoint, back up, take a look at a drawing. This is an image that's pilfered from Google somewhere. But basically we have the aorta, right? All the way from the arch, right? You can see the arch at the top, all the way through the bifurcation, kind of going into the pelvis and out down the legs, right? And so the aorta, the abdominal component of the aorta, begins at the diaphragm, right? And ends at the bifurcation. Again, we've used this analogy before. When you're driving along Main Street and then you cross another street and all of a sudden Main Street turns into another named street, it isn't a different street. It just changes names, right? So it's the same blood vessel, even though it's above the diaphragm or below the bifurcation. But the part that we're worried about, right, the part that's named Main Street, or the part that's named the abdominal aorta, is between the diaphragm and the bifurcation, right? And it's in the retroperitoneal space. It extends between those two parameters, and it generally tends to be left of the spinal column, right? Now, there's people who may have anatomic variants, like if you got total situs inversus and things like that. But generally speaking, if you were to throw a rock at someone and say, are you left or right? You're probably going to be to the left of the spinal column with your aorta, right? The aorta itself has multiple branches, and this is going to be one big thing that's going to differentiate the aorta from the inferior vena cava, right? And so the multiple branches that we're going to be able to at least name anatomically are the celiac trunk, the superior mesenteric artery, the renal arteries, and the inferior mesenteric artery, right? And so you can see in this image, right, the top one is the celiac artery, or the celiac trunk, and it branches into the common hepatic artery headed off to the patient's right, and then the splenic artery heading off to the patient's left, right? And you'll see that bifurcation when we get to the ultrasound component. A couple centimeters distal to that, we're going to have the superior mesenteric artery, right? And this is the one that basically lays on top of the left renal vein. And so we have, this aorta laying next to the IVC, right? Each of them have branches, and each of the branches have to cross midline. And so things on the right side of the aorta need to cross the IVC, and things on the left side of the IVC need to cross the aorta, right? So the left renal vein has to cross over the aorta to get to its target organ system, the left kidney. And so it's going to travel underneath the superior mesenteric artery, right? And I know back in my medical school, they called this like the anatomical nutcracker, right? And you can have nutcracker syndrome, where there's a intrinsic or extrinsic compression of the left renal vein from the superior mesenteric artery. But it's there, right? And then if you travel down a little bit further distally, it's not shown in this image, but it's definitely there anatomically, you have the inferior mesenteric artery on the anterior surface of that, the aorta. And the SMA and the IMA both form kind of these arcades of vessels that essentially provide the vascular supply to the gut, right? Now, off to the sides, you have your right and left renal artery, right? And these are going to branch off the sides. One's going to go posterior to the IVC. That's the right renal artery. It's really important landmark that you can see on ultrasound. And the other one, left renal artery, is going to go directly over to the left kidney, right? And so those are the different branches of the aorta. And we'll see those, most of those sonographically on our ultrasound, right? Now, from a take a tape measure to it dimension standpoint, the abdominal aorta is going to be about 10 to 20 centimeters long. We never measure the length of this aorta. It doesn't really matter, right? It goes from one place to the next. But the diameter becomes really important, right? So typically the aorta is less than 3 centimeters in diameter, right? So anything that's greater than 3 centimeters is technically, by definition, considered an abdominal aortic aneurysm. Now, we know from previous slides that a 3.2 centimeter aorta is very different than a 5.2 centimeter or even a 6.2 centimeter aorta. So there's decisions that can happen within the context of how big it is. But by definition, a normal aorta is going to be less than 3 centimeters, right? And then once you go down to the bifurcation of the aorta into the iliac arteries, it's going to be less than 1.5 centimeters in diameter is the typical size of these iliac vessels, right? And so those are important numbers that you'll need to keep in your memory as you scan these patients with a AAA or for AAA or with aortas, right? Now, if we apply the ultrasound probe to that, we get something that looks very much like this in long axis, right? So here is a view of the aorta in long axis. So you can see the liver in the near field and kind of the superior portion or the left-hand side of the screen for you guys. And then below that, in long axis, stretched out below that is the aorta, that bright, or that not bright, this dark black stripe in this image. And if you look below that, you can see kind of these different periodic lumps, right? Those are the spinal components, right? The vertebral bodies that are going to be deep to the aorta, right? And the reason that we know that this is the aorta is if you look just anterior to the aorta, you can see a couple of vessels that are branching off. One that goes south, right about there. And then one that goes north that originates just above it, right? And this is going to be the celiac artery and the superior mesenteric artery. The superior mesenteric artery goes to the right of the screen. The celiac artery is going to go to the left of the screen. And these are the key thing that will differentiate the aorta from the IVC when you're scanning in long axis with these patients. Right now, if we scan a little bit further down, you can hit up the bifurcation of the aorta. And this view is a view that's taken of the aorta just off to the side. So usually what I'll do is I'll move my probe over towards the patient's right-hand side and angle back or fan back toward the aorta. And you can get a little bit of the bifurcation with the left and right iliac arteries to show the distal portion of the aorta. And this is pretty much the long axis view of the aorta. Now, the important views, the ones that you're going to want to look at, are the short axis views. And not that these are unimportant. You can definitely get a really good AP diameter off of these. But when we go to a short axis, we get a nice circumferential view of the aorta and the surrounding structures. So this image here shows the proximal portion of the aorta. So you can see the liver in the near field. You can see the two large circles, right, that are about halfway down the screen, and then this upside down U shape that's in the very, very far field of the screen. That upside down U is going to be the vertebral bodies, and then those two circles are going to be the aorta. And in this image, since we have this configured in the traditional probe indicator towards the patient's right orientation, the structure, that circle that's going to be on the left, your left, right, is going to be the patient's IVC. It'll be on the patient's right. And the structure that's going to be on your right, right, that circular structure is going to be the aorta, right? You'll see those adjacent to one another. And as we scan through here, you can see there's a branch coming off the aorta, and that branch bifurcates, right? And that is the celiac trunk. This one's kind of a little bit of a tortuous celiac trunk. So it comes off towards the patient's left and then loops back towards the midline. And then right about there, you can see that it branches into the splenic artery that goes off again towards the patient's left, and the common hepatic artery that goes off towards the patient's right and towards the liver. So that's going to be the proximal view of the aorta. If we scan down a little bit further, we get to the mid view of the aorta, and this is going to be at the level of the superior mesenteric artery, which is where the arrow is pointing in this patient, right? And so we see the aorta, again, deep in the field. You see a long axis vessel that's between the aorta and the SMA, and that's going to be your left renal vein, right? Remember that left renal vein has to cross over the aorta to get to the left kidney. So it's going to be the left renal vein. It's always going to be between the SMA and the aorta. And then as we scan through, you can see occasionally there's a vessel that goes across the patient's abdomen again, but above the SMA, right? And so if we go clip through right there, right, you can see that that's going to be your splenic vein, right? So the splenic vein forms with the IMV, or the inferior mesenteric vein, to form the portosplenoconfluence and become the portal vein, as you transition more towards the liver, right? But as we see it in this view, you're going to basically have that sandwich of your splenic vein on top, your SMA inside, and then the left renal vein on the bottom, and then the aorta is undergirding all of that as you kind of think through the different structures that are in this area. And so this has often been is called a number of different things. I've oftentimes looked at it in the context of a donut. You can see that bright halo, a bright echogenic halo around the SMA. One of my previous colleagues who has subsequently moved on to a different place, used to call this the mantle clock sign, right? So it kind of has that kind of swooping mantle clock with the clock face. The SMA is the clock face inside of it. I mean, we can do some cycle analysis and kind of do these ink blot tests and figure out what, this tells us about our internal desires and longings and our relationships with our mothers and things like that, whether it be donuts or mantle clocks. But whatever one you choose, whatever one you like, both can be helpful in terms of describing kind of the echogenic surroundings of that SMA and help us identify that structure. So with that being said, we're going to move on towards the distal portion. And as we scan down, once we get past the SMA, it really gets to be quite boring, right? You're going to have just the aorta. You won't sonographically see the inferior mesenteric artery generally. And at some point, right, generally around the T10 thoracic level or the belly button, if you want to go surface anatomy around that level, that aorta is going to bifurcate into the left and right iliac vessels, which we see happening as we kind of scan distally here. The one vessel becomes two, right? We're going to scan, into and slightly through those iliac vessels to look and see if there's any aneurysms at that location. So that's going to be the three places, the proximal, mid, and distal in the transverse oriented aorta that we want to scan as we do these studies. So with that foundational basis laid, right, with that understanding of normal like gross anatomy and normal sonographic anatomy, what are we looking for that would be described? It would be the definition of the pathology that we're trying to find, the AAA pathology, right? And we're really looking for kind of two things, right? One would be an enlarged diameter of the aorta, right? And the other one would be a thrombus with a residual lumen. We typically see both of these things, right? The key being the first one, right? The enlarged diameter. And when I say enlarged diameter, right, and we're going to see this in a number of images coming up here, you have to measure from the outside of the aorta, right, the outer wall of the aorta, to the other opposite outer wall, right? And we're going to see that the residual lumen can oftentimes look like a normal aorta or mimic a normal aorta, but the reality is the patient actually has a AAA, and you need to measure the outer wall, that outer adventitia, to the outer adventitia before you can say that you know the exact diameter of this aorta, right? So that said, let's look at a couple cases and help us understand what these things look like and the variations that you can see as you might be scanning these patients. And so the first one here is this particular patient, right? We see just a still image, cross-sectional or transversely oriented image somewhere in the mid-abdomen. It's hard to say because there's not really a lot of residual anatomical landmarks around the thing, but you can see that bright red splotch, of blood flow that's picked up by Doppler. And that's going to be the residual lumen. But if you notice, around there is a larger rounded structure, right? You can see the diameter is 2 to 3 times the diameter of whatever that red splotch is, right? And so the entirety of this thing, right, from outer wall to outer wall is the AAA, right? And so if we correlate, I don't have calipers on it here, but if you look at the centimeter measurements on the side of the ultrasound screen there, you can see that this is probably going to be somewhere in the neighborhood of about 7 to 8 centimeters if you want to correlate the size of that scale on the side with the actual structure that we're looking at, right? And if we go in long axis, we can see you can see blood flow into that residual lumen, and the residual lumen itself is going to be enlarged, right? If we measure that, it's going to be big. But as we scan up and down on this thing, you can see that there is a large thrombus or echogenic thing kind of on either side of that lumen that is the thrombus inside the total adventitia of this aorta. And think about it, right? So based on Laplace's law, right, the tension on a wall is related to the diameter, right? And so if you take a balloon, just for the sake of example, and blow the thing up, and actually let's just make this a humorous anecdote, right? One of my sons this year had a birthday, as he does every year, as is his custom. And instead of going out and getting balloons at the party store, which is typically my custom, I kind of got caught behind with logistics this year. And so for this particular son, we blew up some balloons that we had at home. And so one of my other sons decided to blow up the balloons, and he has not yet learned that you need to stop at some point because the balloon will burst. And so we're minding our own business, and all of a sudden we hear this big bang from when one of my sons, my oldest son, was blowing up the balloon, and the thing exploded in his face, right? And we all laughed about it. It was kind of funny until it happened again and again and again. And then we had to say, hey, stop blowing up balloons because you keep breaking them all. But the point of saying this is, look, you have this balloon. If you blow it up so far, right, it's going to pop. Now, let's say for the sake of the example, we blow up a balloon to the point that it doesn't pop and measure how much air is in the thing, right? X many milliliters of air, right? And then we put that equivalent amount of water in the balloon and then put that equivalent amount of air in the balloon. What do you think is going to happen? It's going to pop, right? Because it doesn't matter what that thing is inside the balloon. The wall of the balloon has been distended beyond its physical capacity to be able to hold itself together, and it releases all of its contents into the atmosphere of the world, right? And the same is true for the aorta, right? The adventitia of the aorta has a certain ability, and even that medial layer has a certain ability to withstand wall tension and wall stress, right? And so as you increase the diameter of that wall, right, the tension on that wall, at some point it's going to rupture, right? And it doesn't matter what you put inside the lumen that prevents it from rupturing. The wall tension is going to be the thing that kind of holds it all together. And so in this situation, right, to bring this all back home, the lumen doesn't have to be the same size as the adventitial wall. Like that thrombus itself could be contributing to the size of the overall size of that AAA. And so that's going to, in addition to the size of the lumen, going to add to the stress that this thing is receiving and the likelihood that this thing's going to rupture. So long excursus to say, you got to measure from outer wall to measure this thing and include that thrombus in your measurement because that is part of the AAA, right? Moving on, here's another case. I think we beat that one to death. So here's actually probably the same thing, same case, scanning down through it. And you can see that lumen has a varying size based on where you're at, right? But you can see all of that echogenic thrombus. And since it's kind of almost isoechoic with the liver, it can be not too hard to miss the thing if you're not specifically looking for it. We can see a very disorganized, heterogeneously echogenic thrombus, but you got to conclude the whole thing, right? Here's another example from a different patient. You can see in cross section, this one's actually measured from outer wall to outer wall. It's about 6.3 centimeters, and you can see that residual lumen on the inside. That actually, in this one, it's it could be easy to mistake that small echogen or anechoic lumen inside there as the aorta and just measure that, but you got to measure the whole thing, right? And if we turn on long axis, here it is where you can see it goes normal, and all of a sudden it becomes aneurysmal, right? You see that 6.3 centimeter long axis of the aorta, and here's another image just isolating down to there of that aorta. It's very focal in terms of where it's at, but it is a fusiform aorta. And so this brings up another interesting point of most of these aneurysms tend to have this fusiform appearance, right? They kind of grow on both sides of the aorta and then kind of shrink back down. And most of these are going to be infrarenal, so below the level of the renal arteries, because that's the most common type and most common place. And it's really important to identify as best as we can the type of aneurysm and the location so that we can communicate effectively to our surgeons, because it's going to affect what they do for these patients, as opposed to one that's going to be very, very proximal or above the SMA, or it's going to have like the saccular appearance, because there's going to be various different things about that may affect their care, right? Finally, here's another example. Again, this one, you don't really see a clearly defined lumen. You can see kind of this smudge at the top, but you definitely have an 11 centimeter rounded structure that's echogenic inside this patient's belly in the location where the aorta is supposed to be, right? And so this is the patient's 11 centimeter AAA. So with that said, let's move on to how do we then scan these patients, right? How do we logistically do it? Where do we put the machine? Where do we put the patient? Where do we put the gel? Where do we put the probe? Things like that, right? So from a logistics standpoint, we're going to put the patient supine on the bed. Most patients are on the bed, so it makes it really, really easy, right? You want to do the transducer in the midline of the abdomen. And you can choose how you want to start, whether you do in long axis or short axis, but you start in whatever axis you want, identify your landmarks, and then kind of go from there, right? You're going to scan all the way from the xiphoid process, right, all the way down to the umbilicus, or basically past the point where the patient would have the bifurcation of the aorta into the iliacs. But from a gross anatomy standpoint or surface anatomy, it's going to be roughly from the xiphoid to the umbilicus, right? From a machine standpoint, you want to use the curvilinear transducer. It's going to give you that depth that you need to be able to evaluate intra-abdominal components, right? You're going to select the aorta preset. At least if you're down in our department, you may need to select an abdominal preset if you don't have an aorta specific one. And this is largely because it's going to, basically create the different parameters that you need the machine to be set at to optimize your ability to to perform the study. You don't have to punch in all those, depth and gain and, contrast and all sorts of other parameters that you can set on these patients, right? So set the aorta preset using the curvilinear use the curvilinear transducer. And the next thing is identify the landmarks. So like I always say when I'm teaching, you have to identify the landmarks first, right? And so you can work your way from one anatomical structure to the next by identifying known landmarks. And so in this situation, you need to identify that you're scanning the proper anatomical structure by identifying the surrounding landmarks. And so here we see at the very bottom, you can see that upside down U, it's going to be the vertebral body. The two vessels just above that to the left and to the right is going to be the IVC and the aorta respectively. And then from there, we can adjust, our gain, adjust our depth, adjust all the parameters we need to get the image optimized so you can have your vessels in the middle of the screen. And then we can look for the surrounding branch points, right, to really identify that we're on the structure. And so if we're in long axis, you want to look for that celiac trunk and you want to see that SMA, right, those two different structures that guarantee that you're on the aorta and not the IVC, right? And then in cross section, you want to look and see the aorta with the different branch points at the different anatomical locations. And this is really important. I've definitely in my career QA'd, at least one study, if not more, where the provider gave me a beautiful view of the IVC and not the aorta. And so it's really, really, really important that you identify the branches off the aorta so that you know that you're evaluating the proper vascular structure so that you don't inappropriately miss their aortic pathology, right? So as we're scanning kind of proximal to distal, you can see the celiac trunk. It's going to be that trunk with the bifurcation, or the seagull wings, as they're traditionally referred to in different textbooks. So here's the live view of that celiac trunk as it kind of comes off and bifurcates. And then the SMA is going to be the other anatomical landmark with that mantle clock or donut. And it's going to have the left renal vein underneath it and the splenic vein above it. Right. So those are going to be how we're going to scan the landmarks that we're going to look for. What about pitfalls, right? We talked about the pathologic finding, but what are the things that we may do in our scanning or encounter in our scanning that may get us tripped up or confused, right? And so the first one is really scanning with the inappropriate depth, right? And so in this situation, we're adjusting the depth here to bring the aorta back to the middle portion of the screen. But at the very, very beginning, it is very small and very close to the top. And so if you don't adjust your depth appropriately, if you don't identify your landmarks appropriately, you're going to be looking for a large structure that you'll either overcall some other vessel as your aorta because it's too big, or undercall because you can't find the aorta if all of a sudden your depth is too great, right? And so what I like to do is I like to find the vertebral body, right? You can see that hyperechoic rim, the upside down U, the hyperechoic rim with that deep, dark shadow that kind of extends to the rest of the screen, right? You identify that and then adjust the depth. So that's at the bottom of the screen, and the vessels that are immediately above that, which I know to be the aorta and IVC, are somewhere towards the middle of that screen. Maybe just a little bit, below middle, but close to the middle of that screen. And once I'm there, then I consider that to be appropriate level of depth so that I can then move on and evaluate the rest of the structures, right? The aorta up and down its trajectory, right? The next pitfall that you may run into is scanning the wrong vessel. And so in this situation, this is the IVC, right? And we talked about this just a moment ago. It's really, really important that you identify the aorta, not the IVC, because if you scan the IVC, you will miss all of the aortic pathology, right? And it's really easy to do, right? The two of them live right next to one another. It's a centimeter or two movement on your probe, and you're on the other one, right? And so as you're scanning, you want to very, very closely scrutinize, is this the aorta? Is this the IVC? And so particular landmarks that you will see in the aorta is the anterior branching of that aorta. You'll see the celiac trunk, and you'll see the SMA, right? If you see that, you're good to go. For the IVC, what you may notice is that it extends up beyond the diaphragm and goes directly into the right heart. That's a pretty good telltale that you're in the IVC. The other thing you may notice is that posterior to the IVC, you have that right renal artery, which you will not have a vessel posterior to the aorta, right? So if you see a cross-section view of a small vessel posterior to your large, long one, you really got to ask yourself if you're on the IVC and not the aorta, right? And I guess this is a good time just to insert, you may not be able to rely on pulsatility alone to be able to help differentiate the two, right? And I say this for a couple of reasons. I mean, number one, the aorta is generally pulsatile, right? If you're dead, I suppose it's a different story. But generally speaking, even if you have a very faint pulse, you can visually see some pulsatility on the aorta. However, the IVC, since it's so proximal to the heart, you are going to have some pulsatility to that as the patient has that, goes through the cardiac cycle, right? If you remember back to medical school, you can see like those carotid or the venous pressure waveforms superimposed with the heartbeat and the carotid, waveforms and all that. You will see some reflux of blood flow into the IVC from the beating heart, which will provide some pulsatility. So you can't rely on that exclusively to differentiate one versus the other, which is why I say anatomically you want to look for those branch points or the trajectory of where the IVC or the aorta is going, to really scrutinize and confirm you're on the right vessel, right? The third pitfall, we kind of hit this one a lot earlier on, but not measuring the thrombus, right? It's really, really important when you're measuring these things to actually measure from outer wall to outer wall, adventitia to adventitia, because that's what receives the stress, right? That residual lumen that we see here, that black lumen there, that one may or may not be subject to stress, right? Because it may not be dilated, right? But as you stress that wall, as you have that residual thrombus that's kind of in there, that will stress that outer wall, increasing the risk of rupture, right? And so you really, really want to measure from the outer wall to outer wall, not just the lumen, and really be training yourself to look specifically for that thrombus that surrounds that anechoic lumen, right? And then the final pitfall that I want to mention is overlying bowel gas, right? And this is sometimes just, a limitation of the study where you just cannot, work around it, right? We know that air blocks ultrasound, right? If you put air in the overlying bowel structures, you may have some shadowing that precludes your view, right? And if you can't see it, then you can't call it if it's there. And so I bring this one up to say a couple things. Number one, do what you can to either provide some compression to move that bowel gas out of the way, right? So sometimes you can just provide pressure, gentle pressure over the aorta, and the bowel gas will be displaced to the side. You can kind of part that curtain. Or your other option is you can try to move your probe to the left or to the right to get around it, right? And so sometimes you can go to the patient's left and look back, the patient's right, look back, and see if you can get underneath that loop of bowel that's got air to really see this patient's aorta. And, if you're up against the wall and really can't do it, maybe just give them some time and come back, right? And see if, with a little bit of peristalsing action, that thing can move along and you can start seeing it, right? And certainly there are a lot of cases where we'll say, okay, I missed this 1 centimeter here, or missed this 2 centimeters here, but I can see kind of around and above. It may be, and this is going to be very situational dependent, it may be that you can actually kind of mentally construct a model of what the aorta looks like in your head, even though you haven't completely seen every segment of it. I think it'd be fair to say it's probably reasonably, it's a reasonably low probability event to have an isolated fusiform aneurysm in 1 centimeter or 2 centimeters of an aorta and not see it elsewhere. And so if you can see, if you miss 1 or 2 centimeters here and there, you can call it limited and potentially use that data. And I'm kind of getting out on a limb here, so I should probably walk back a little bit. But the more, I guess the message I want to say is the more that you see limitations to your view, obstructions to your view through air, the less you can rely on your study, right? And it may just be that at the end of the day, you can't get the study that you want, right? And you have to find your answer with other ways and other means, right? Maybe you just need to CT the patient in a patient that you would ordinarily just get an ultrasound because you cannot see it despite your best efforts, right? And so there's no shame in doing that if your back's up against a wall, but know that the bowel gas can provide a limitation to your visualization. And that while there are strategies to mitigate that, at the end of the day, it may not work. You may have to work this up in another way before you just kind of blow it off and say, oh, there's nothing to see here, right? So with that said, let's do kind of a little bit of a review, right? So we talked a lot about some basic ultrasound here of the aorta, specifically looking to identify abdominal aortic aneurysms, right? And so how we want to do this, right? You want to look just left of center, right? Put your probe down, look left of center. That's generally where the aorta is going to be. Look for the branches to confirm that's the aorta versus the IVC, and then measure the thing, right? If it's less than 3 centimeters, you're good to go, right? If it's greater than 3 centimeters, you got some aneurysmal problems. And if it's greater than 5, your risk of rupture is starting to substantially increase to the point where you need to start involving your vascular surgeons to make a plan for what to do for this patient. Like, you have to consider, could this thing be ruptured today? Like, if they're over 5 and they got belly pain, you're probably CTing the patient, right? If you're over 5 and you incidentally find it, well, then you need to start talking to some folks to either coordinate follow-up or get them to see the patient in the department. So these are various different aspects of the care that can be highly nuanced from patient to patient. But generally speaking, over 5 to 5.5 centimeters, your risk of rupture increases to the point where you have to really, really worry about this thing and work the patient up appropriately. So with that said, any questions about aorta ultrasound specifically, or anything that we said specifically? I'll open up the floor and take questions or comments.